here today, comfortably at home, but connected with so many of you, maybe at next door or from different countries, I don't know. But this is the great potential of the web. We are living in unprecedented times. The COVID-19 calamity has affected our life and forced us to stop and pause for a while. The pandemic surprised every sector of society and caught many people unaware and unprepared. And it is preventing us from running our normal life and also from getting physically together with our friends and colleagues. But smart working and networking are powerful tools to keep in touch and share knowledge with colleagues from all over the world in order to get updated and deepen focused topics related to all branches of interest. You know, currently there are plenty of webinars available on the internet, particularly on social media, but most information is based on anecdotal reports. Differently, when we thought about this webinar, powered by our dental blog Zerodonto, and I catch the chance to thank my fellows, Dr. Fabio Cozzolino and Dr. Anna Mariniello, as well as our CEO, Ciro Bocchetti, we decided to propose a case presentation focused on the state-of-the-art of aesthetic restorations in anterior areas, followed by a panel discussion with some of the best worldwide experts on this topic that I'm going to introduce to you in a while. During the lockdown, it was meant to be a way to provide an opportunity to meet and question some of the most qualified academicians and clinicians from top-notch universities. The idea was born as a joint venture between the University Federico II of Naples, the University of Siena, our group Zerodonto, and for the first time together, and this is a great pleasure, the web community of Style Italiano. We hope that these three initiatives will receive your enthusiastic approval. Just a quick reminder, you can ask questions writing on Facebook and YouTube. They will be collected in real time, and we will answer them during the panel discussion at the end of the case presentation. Now it's time to introduce our very special chairman that will tickle your curiosity and will offer their broad knowledge regarding the hot topics that will be discussed in this case presentation. My scientific mentor, with whom I've shared and I'm still sharing so many wonderful years while studying during my PhD program, first and then teaching at the University of Siena, Professor Marco Ferrari, is Dean of the School of Dental Medicine and full professor of prosthodontics and dental materials in Siena, visiting and research professor at different international universities, among which the Tufts University of Boston, past president of the Academy of Dental Materials, president-elect of the European Prosthodontic Association and of the Dental Materials Group of the International Association for Dental Research. Moreover, recently has become a member of the Italian Supreme Court of Health. Professor Ferrari made me aware of the pleasures of Brunello of Montalcino, as well as of the fascinating world of laboratory research, and I will be always grateful to him for his teachings and friendship. He is a tireless researcher and excellent clinician. He is for me a model, since he is well known worldwide as one of the most clever minds in the scenario of prosthodontics. Professor Angelo Putignano, Dean of the School of Dental Hygiene and full professor of restorative dentistry at the Marche Polytechnic University, past president of the Italian Society of Conservative Dentistry, founding member of the Italian Academy of Aesthetic Dentistry and active member of the European Academy of Aesthetic Dentistry. Moreover, he is one of the founders of the Style Italiano community and is lecturing all over the world on additive and aesthetic restorations. Over the years, I had the chance to follow Professor Putignano in many lectures and hands-on courses, and I can state that besides being one of the most stylish and trendy professors we have in the Italian Academy, he is also an extremely talented clinician with an utmost esprit for shapes and colors. And last but not least, indeed only in alphabetical order, my master, Professor Fernando Zarone, full professor of prosthodontics and digital dentistry at the University Federico II of Naples, past president of the Italian Society of Prosthodontics and Implantology, active member of the Digital Dentistry Society and of the Italian Academy of Osseointegration, and the list goes on. Apart from being a clever researcher and an astonishing clinician and one who made me become fond of academic teaching and clinical prosthodontics, he is probably the most enduring person I know, since he has been tolerating my fellowship for more than 20 years. In all seriousness, I could talk about Professor Zarone for hours, but I don't want to bore you. I just consider him a model, a mentor, and a great friend of mine, and I just have to say thanks for his knowledge, his passion, and his never-ending teachings. Now, I would like to give the floor to our appreciated chairman for their greetings and a brief introduction to this session. Professor Ferrari, please.
Yes, today we have a very nice and unusual organization in which we have, first of all, 3 universities connected, and then 2 big social group in dentistry, the 2 biggest in the world, probably. And we have a special presenter, Professor Sorrentino, that, as he say, he was scientific son for me, like also for Professor Zarone. And I'm sure that you'll really enjoy the presentation. In particular, you'll enjoy the discussion, you'll enjoy step by step how Roberto organized the presentation in order to make questions and to discuss any choice was made for the pre-treatment planning. And that is what dentists need.
Professor Putignano, please.
So I'm very happy to be here in this panel discussion. First of all, because in my opinion, it's the first time that there are a very talented speaker that I knew since he was really a student in the undergraduate. So it's unbelievable to have people that is not only professor in the university, but are also the good clinician. In my opinion, that's very important to filter what is written over the papers, book, and to have an experience in order to put together and allow really to suggest what is the best for the general practitioner, because in my opinion, we have to help people to grow in their daily practice. So I'm very happy to be here, invited by these wonderful guys and friends that I know since probably more than 30 years, and to stay together, Stella Italiano and Zero Dotto, is the first time that we collaborate, and I hope that will be the first of a long series of collaboration.
Thanks. Professor Zarone.
Thank you so much. I wish all the best to all of you and your families in this time of sad lockdown, or better, alas, of a real parole. But let me add something that probably will not please many. As a matter of fact, with all due exceptions, lately, I don't like the uncontrolled phenomenon that we are witnessing in these months of widespread webinars. In the last week, I have counted not less than 15 blah-blah-nar promotional mails per day, the most of them with speakers fairly unknown to the scientific community, not to say sick of social protagonism, fishing for auto-celebration and for Facebook likes in such a serious and sorrowful moment, with all due exceptions. And this is one of those. I've known Marco Ferrari for 30 years. From the times of Tufts University, we consider ourselves as brothers in research, and mostly we are good friends. Then when Angelo Putignano is present, how to say no? Another good friend, one of the top Italo dentists ever. And Roberto has been with me since he was still in diapers. He's facing the problem of diapers at the moment with his beautiful child. And now he's still every day with me at our university department. All this is warranty of quality. And I like the didactical, simple topic that will be discussed in a friendly chat and in the light of scientific evidence and daily experience. So here we are, really happy to join you.
Thank you very much for your introduction. Before starting, I just would like to remember to all colleagues that during this session, you can comment and ask questions specifying your country of residence on the social media, and then we'll discuss them at the end of the case presentation. Well, now it's time to start, and recently I have listened to an interesting lecture regarding social sustainable dentistry, highlighting how sometimes we are used to overestimate cosmetic issues in our treatment planning. For sure, dentistry is not a branch dedicated to save patients' life,
but the importance of oral health and impact of psychological implications of missing teeth in everyday life are undeniable. And in the last decade, improvements in material science have dramatically changed the clinical approach to prosthodontics. The development of innovative technologies has moved in parallel with the rapid evolution of restorative materials on the rails of digital dentistry, opening new horizons in the field of prosthodontics. We are experiencing a period of significant marketing and technological innovations that allow us to modify our clinical approach by means of more conservative procedures and restorative materials more and more performing, but always following the principles of good clinical practice on the basis of prosthetic paradigms, as we have highlighted in these recent publications. And when we talk about aesthetical prosthesis, we are used to think of trendy and fashionable adhesive restorations, just like ceramic veneers or tabletops. But it is worth remembering that the guidelines to achieve satisfactory aesthetic and functional results are the same if we manage with tooth-supported, implant-supported, and removable prosthesis as well. Of course, the classical paradigms of precision and accuracy have to lead any treatment plan, profiting by the best properties of innovative restorative materials and updated techniques. And the conventional principles of prosthodontics have to make us deliver precise and biocompatible restorations that could guarantee not only aesthetics, but also good function and serviceability over time. And modern prosthodontic technologies and latest generation restorative materials allowed to reinterpret somehow traditional dental preparations in a more conservative way. The use of metal-free materials, just like zirconia and lithium disilicate, enables to prepare the prosthetic support with a minimally invasive approach, saving a significant amount of dental tissues and achieving optimal biointegration, factors that represent the key to success over time. Moreover, the achievement of success is strictly related to the comprehensive understanding of the case to be treated. It is worth noticing that the single specialized dental expertises influence minimally the prognosis, while the correct formulation of a treatment plan is for sure the key to longevity of restorations. Treatment planning is 100% operator related and depends on personal skills and attitude, clinical expertise, and proper understanding of patients' needs and expectations. And when we outline a treatment plan, we have to evaluate carefully these clinical variables and risk factors, keeping in mind the final result to be obtained. Then we can go for analog treatment planning on the basis of the conventional functional and aesthetic parameters of aesthetic dentistry, or we can set a pure digital prosthetic project based on the so-called backward approach, designing the ideal final volumes of the restorations using digital phasebows, articulators, and CAD softwares that allow to analyze all the static and dynamical variables of function. And correct treatment planning is crucial, particularly in very complex cases in which an interdisciplinary approach, significantly based on the communication between the dental team and the patient, is paramount to compare the different steps of the treatment with the baseline project, so as to correct and fix any possible drawback till the achievement of the desired final result, fulfilling the patient's expectations. Synthetically, the clinical success has to be based on a correct treatment plan, for sure. It is a complex process, but has become, thanks to the recent developments offered by digital tools, a workflow merging different specific skills inside the dental team, so as to satisfy the patient's needs with the most appropriate individually driven treatment. And after this brief introduction, necessary to trigger possible provocative discussion points, let's move to the presentation of the clinical case meeting our patient. I would like to introduce to you Sarah, a lovable 18-year-old lady, very funny but pretty shy, and their maxillary central incisor were not helpful in increasing her self-esteem, as you can see. She was complaining of the shape and color of her front teeth. She is a volleyball player, and after a trauma involving the incisal margins, she had already been treated twice with unsatisfactory composite restorations. As to the clinical examination, she presented with acceptable conditions of oral hygiene, no signs of parafunctions, and no general contraindication to restorative treatment, but she was a moderate smoker, and this could explain the early and consistent yellowish appearance of the composite restorations that presented a bulky appearance, as you can see, with wrong shapes, particularly at level of 2.1, no surface texture, and marginal staining, indicating unsatisfactory finishing and polishing, and probably an early stage of micro-leakage. So, turning on the detection mode of a latest generation light curing unit, it is easy to identify the extension of resin composites, profiting by the wavelength of fluorescent light. We can quickly outline much proper shapes, drawing the contours of harmonic restorations. It is not a digital smile design, but it's just a 2D digital project that can help in identify the aesthetic aim of the treatment. And after the previous traumatic injury, 1.1 got necrotic and was in need of a root canal treatment. It's time to define the treatment plan. And of course, we have many different options. We can do nothing. According to forensic odontology, we have to inform the patient that she can survive with anesthetic restorations. She won't be very happy, but she can. We can substitute the composites with new and proper direct restorations. It is possible to fabricate indirect ceramic prosthesis, or we can choose a combined approach. And before showing my personal choice, I would like to ask the opinion of the chairman. Please.
Marco,
okay.
First.
Yes. First of all, I would like to stress the aspect that we may take consideration also for combined intervention. But anyway, apart of that, so we have not just to select one kind of restoration, one solution for all teeth we have to consider. But in particular, I would like to make the question to Roberto, what about the substrate? So how the substrate can influence us in the decision, the final decision?
Well, we will go deeper on this point in a few minutes. Anyway, of course, the analysis of the dental substrate is crucial to decide if you prefer to go for an adhesive restoration, both direct or indirect, or for a traditional full contour crown. But we'll see it in a while.
Angelo.
Okay, so a very interesting case, really, because you have really different options. No? First of all, the option, in my opinion, has to be chosen. It depends on what the patient wants, or better, what the patient needs and what we can do. Because some of us are expert in direct restoration, some other are expert in indirect restoration. The ideally treatment plan, in my point of view, the age of the patient, that is 18, I would like to wait for some years. So for me, the best one is at the moment the new direct restorations, or if you can do two very simple indirect veneers in composite. Waiting 33, 24, in some paper they indicates 25 years to finish their options. I saw in the slide that probably she has a little bit of gummy smile. So that's very interesting treatment plan. But overall, what the patient requires is very important. So this is my humble opinion.
Professor Zarone?
Okay, Roberto, you know that in our school we share our knowledge, our treatment guidelines, and why not philosophies too. So in this treatment plan, I think that I would go for a prosthetic restoration. Prosthetic restoration is my choice. I agree, there is no one-way therapy in any field of medicine and surgery. We should not be absolutist, especially when we deal with aesthetic treatments. The rationale can be one and unique. I would go for probably one crown and one veneer, full ceramic bilayer desilicate, or also why not two crowns? In this particular case, the color is not a major issue. It's quite easy to get. Not many characterizations are needed. But if it was trickier, probably 2 crowns would be better. When dealing with a different thickness, like a crown and a veneer, the final effect can be unhomogeneous. And in the anterior area, mainly when we talk about 2 mirroring incisors, 2 crowns could be a choice. And don't forget, there is another risk factor. That's composite restorations, more interfaces exposed to the oral environment, and the aesthetic transparency can create some problems. That's my opinion.
Well, thanks for your opinions. They are all completely agreeable and viable. And I guess I was mainly in the middle, because my first proposal to the patient was the substitution of the old composite fillings with new direct ones because of the age of the patient. But on the basis of her previous experiences, the patient did not accept. She's a young lady, she's a smoker, she doesn't want to face the risk of recurrent discoloration, and she asked me for something more stable over time. That's why I switched to indirect ceramic restorations, but I repeat, all the treatment plans were definitely viable. In particular...
Excuse me, Roberto. As regards growth, I agree with Angelo. Angelo, you are right when you say that in girls, growth can go on beyond 18 years, but we are talking about exceptions. The only case I have seen is Roberto's cousin. Roberto, you remember her? And we treated her together, and we had a problem. But for this matter, dwarves stop their growth much before, but we cannot accept any variable in for our future treatment plans.
Well, definitely. In fact,
I totally agree with you. You have to take care of this fact.
Sorry.
Sometimes to be a problem, she spent a lot of money. Don't forget, you can go for 2 veneers in composite for 4 years, 5 years. You can tell them that they will not pay. You can include in the next treatment plan, so they pay now what they will have in discount after 4 or 5 years. And this way you feel better, in my opinion. But for sure, I totally agree with you. Me too, okay. I did a lot even before. But I had 2 problems in my life that I still remember very well.
The problem is I'm very inexpensive, so no problem with my crowns. 1 crown of mine costs like 1 composite made by Angelo Putignano. That's why.
No, it's a joke.
Okay.
Let's go ahead with Roberto, and let's see what is going on.
Treatment planning as well. Okay. Anyway, in particular, I went for a full crown onto 1.1, taking into consideration the necessity of the root canal treatment, and a laminate veneer on 2.1. And it is worth remembering that non-vital teeth are not an absolute contraindication for porcelain veneers, but according to the literature, a crown is much more reliable over time due to the brittle biomechanical behavior of endodontically treated teeth. And as usual, I performed a careful static and dynamic analysis of occlusion in order to evaluate the available prosthetic room and to design the proper occlusal scheme so as to make the restorations restore function and guarantee at the same time the structural resistance and serviceability of ceramics over time. The maxillary arch was regular and properly shaped, so I just recorded the intermaxillary relationships with an additional silicone specific for bite registrations. Then I made alginate stud impressions to transfer all the clinical information to the dental laboratory and mount the diagnostic casts in articulator. Subsequently, a wax-up was made to restore proper shapes, volumes, and the incisor length of the central incisors, and a silicone template was fabricated to test the prosthetic project with a mock-up, as we have described in these recent publications. And the proper ditching of the model at gingival level and the scalloped shape of the silicone template allow resin to flow away and clean it up very easily. I always mark a reference point on the midline in order not to strain the resin material. I prefer to use self-curing bisacrylic resins because of their precision, hardness, and polishability. The intraoral mock-up is very useful not only to evaluate and rectify the aesthetic outline, but mainly to verify the prosthetic room and the clinical feasibility of the restoration. And once the project was checked and accepted by the clinician and the patient as well, of course, an indirect acrylic resin temporary restoration was fabricated to start conditioning the soft tissues at level of 1.1 and allowing their maturation. In this case, I decided to delay the preparation of the veneer onto 2.1, since I'm used to check any kind of acute discomfort subsequent to root canal treatment for at least 1 week. And when I go for laminate veneers, I'm used to end up the treatment within 2 weeks to limit as much as possible any contamination of dental substrates. And consequently, in this case, I decided to divide the treatment into 2 steps, waiting for the complete recovery of the endo treatment onto 1.1. The temporary crown was slightly overextended initially to close the interproximal contact area, waiting for a correct redistribution of the prosthetic space between the 2 final restorations. And now we are ready to prepare the laminate veneer, and it is necessary to discuss the preparation protocol. According to the modern principles of minimal intervention dentistry, we can choose among a conventional preparation, a prepless technique, or an no-prep approach, being the latter a really viable approach in terms of biological fading, but sometimes tended to be abused just for a fashion trend, as we reported in this systematic review. Professors, before going on, can you please tell us your opinion regarding this topic, please?
Marco.
Okay, I feel that prep is something very useful in order to provide room for the restoration, for the laminar veneer. We have to consider that according with the literature, there are only less than 5% of cases in which we can perform no prep at all. So I believe that we have to look carefully the possible undercut along the surface, buccal surface of the anterior teeth, and so they must be removed. And then, of course, depends the need we have in the mouth, the position of the tooth, and so on. But anyway, I believe that the wide majority of teeth are prepared or prep less are the choice. Angelo.
Yes, I think that there are different options and are not different techniques, in my opinion, in the sense that you cannot go no prep in all the situations. If you have diastema, it's very easy. If you have a very square teeth, it's possible. If you have triangular with the undercast, it's not so easy. But after that, I think that it depends what you have to do. In this case, probably no prep is totally wrong, in the sense that you have to prepare. You decide to make a crown. That is a very difficult choice, because don't forget that you have 2 different thickness, and you can influence a lot the color with the cementation in the veneer, and really less you influence the color and the cementation for the crown. So in my opinion, if you choose this kind of treatment plan, it's better to provide before the veneer, and after 1 week or 2 weeks where you have a stabilization on everything, to go for the crown. If you go simultaneously, you need a very, very strong technician and a very strong clinician, in my opinion.
Professor Zarone?
I definitely second what has been said. In this case, the shape of the incisors only needs a minor remodeling, so a very minimum preparation is okay, with an incisal butt joint, possibly to get a nice translucency, and also to get a better resistance at the margins. And also a proper positioning of the veneer during adhesive cementation. As to no prep strategy, okay, it's becoming increasingly popular. With my team, we have written this paper. You see the reference on the screen later, probably. No prep is considered as a simplified technique, but it isn't. It should be performed in accurately selected cases and by very skilled clinicians. There is a high risk of fracturing the subtle restoration during handling or during cementation, also simply for polymerization shrinkage. And aesthetic can be impaired by awful overhangs. Moreover, there is no scientific evidence up to now, no randomized controlled clinical trials, no long-term perspective or retrospective studies. Moreover, no prep indications are where there is room for the material. I mean, diastemas, post-orthodontic refinement, microfractures, conoid, tooth reshaping, and so on. In any case, a limited preparation, I agree completely, is needed to smooth and sharp edges and undercuts is always needed, in my opinion. So minimum preparation, but preparation.
Well, thank you very much. I definitely agree with your viewpoints. And in this case, I chose a prepless approach in order to keep my preparations as much conservative as possible, of course. And before going on, it is necessary to point out another issue, the preparation technique. Once again, we can select one out of three options: freehand preparation, depth-checked index technique, or mock-up guided preparation. What is your first choice, Professor Ferrari?
Well, to me, the mock-up guided preparation is the first choice. Well, I can control much better, and I can use several times the same silicone guide for the mock-up, for communication, for prep, for temporaries. So I would go for mock-up guided.
I totally agree with the mock-up guided. If you go for sure, no prep is totally different the situation, because you have your works up. So it's not in your hands to manage the thickness, but it's in the hands of the technician after that when you decide. But mock-up guided, in my opinion, is the best one, really the best one.
Professor Zarone?
Of course. I usually prepare both according to the mock-up driven technique and paying also attention to the silicone indexes. Why not? Templates on the wax up are completely inexpensive and easy to make. Moreover, Roberto, honestly, I'm never in such a hurry when preparing teeth, so time consuming, but if you can get also the aid of such a simple system, it's much better. So both techniques.
Well, okay. According to the literature, it is possible to state that all these techniques are viable options. Although the freehand approach is very operator sensitive and the depth-check index technique can result in more time-consuming procedures. Differently, the mock-up guided preparation is a fast and accurate technique based on the replica of the prosthetic project. In other words, it is just like preparing ideal sound teeth in their ideal alignment and 3D position. Something quick and easy in my hands, and I chose this option. Of course, the precise control of the burrs is paramount, not to damage the soft tissues and to keep the preparation margins within the enamel. And I'm used to using stereo microscope, but any kind of magnifying tools can be helpful to achieve these goals. And it is worth discussing for a while the incisor preparation. 4 different geometries have been described in the literature: the window, on which the incisal margin is not prepared; the feather and the butt joint, where the incisal margin is prepared respectively without and with the reduction of the overall tooth length up to 1 millimeter; and the overlap design, in which the preparation is extended to the palatal surface with a mini chamfer, as we described in this paper on the JPD a few years ago. Of course, the more geometrical the preparation, the more restricted the insertion path is. As a consequence, the window design offers more freedom to sit the veneer, but at the same time, it can slide during cementation, whereas the covering geometries allow for a unique insertion path. The decision to prepare the incisal edge is related to the clinician's preference and is based on aesthetic and biomechanical considerations. But evidences from the literature agree, considering the butt joint preparation as the gold standard to achieve the most predictable clinical outcome and limit possible failures. Professor, do you all agree with this evidence?
Yes, I do. Yes, I do, for sure.
Me too, but you have to take in consideration the WhatsApp, in my opinion, is better to tell to the people that if they have to increase the length of the tooth of 3 millimeters, they are not to cut the other 2 millimeters. As a lot of people is doing all over the world. So
you start from the mock-up. Naturally, yeah, true.
That's very important. But totally, I prefer the butt joint, and clinically speaking, even in the literature, you can find paper, they say that you cannot go in the concavity. So I prefer everywhere. In 35, 40 years of experience with the veneer, I never had a problem about what kind of preparation I did. So if you respect the function, in my opinion, veneer is the best.
Professor Zarone, do you agree? I guess so.
I completely agree. I already said this.
Okay.
And, moreover, I do like the butt joint because we can avoid also the sandwich effect of overlapping different layers of different materials and tissues. Because with window preparation, you have ceramic, the layer of composite or resin, dentin, and enamel. So that's not good from the point of view of the optical properties at the end of the game.
If you manage composite in the right way, you don't need the window preparation, in my opinion. So you don't need veneers if you are not to change something really. If you don't change the shape, if you don't change the color, why you need the veneer? So you can manage with the composite today with the new composites available in the market in an unbelievable way. So
yeah, but we are not as clever as you. That's why I choose to be a prosthodontist.
Well, that's the point regarding the different expertises and the different skills of clinicians, of course. That's a very interesting point, according to me. Well, anyway, don't switch off your microphones because I have another question for you regarding the position of the finish line. Wow. We all know that it is possible to choose among subjuxta or supragingival placement with different indications according to the clinical needs of the case. And what is your opinion in this specific case?
Well, to me, when it's possible, I stay juxtagingival. So I usually respect a lot of the gingival tissue, so I try to avoid the placement of the finishing line into the sulcus. That is my routine approach. Then, case by case, I have to take the choice.
I totally agree with Marco. Juxtagingival, in my opinion, is the best. Even sometimes if you want to manage a little bit soft tissue, sometimes you can go a little bit subgingival, but you have to have the possibility to put rubber dam, everything. So it means that a few cases. Juxtagingival, in my opinion, is the best. Supragingival, it depends. It depends when the CJ junction is, because in my opinion, if you remain over, it's better. But if you have the CJ junction just in the margin, it's better to remain a little bit over. Otherwise, you can go because the CJ junction is 1.5 millimeters, sometimes 2 millimeters under the gingival level. So it depends on the age. In this case, it's a young lady. I suppose the enamel everywhere. So good, juxtagingival.
Professor Zarone?
Marco, just a consideration. Undergoing interrogation by our pupil is quite unusual and weird, or not? It's really strange, very strange. Anyway, given that in our school we have been using stereo microscopes for more than 30 years now, well, are you sure we can detect whether our burr going as fast as 400,000 revolutions per minute is positioned subgingival or juxtagingival? Honestly, it's not that easy. What I do usually is displacing the gingival margin with my retraction cord. Then I try to stay inside the sulcus. And staying supragingival, I mean out of the sulcus, exposing finish lines to the action of oral fluids can be likely to induce pigmentation of the margins. These patients, don't forget, they smoke, drink blueberry, cranberry, blackberry, mulberry juice, not to mention curcuma, turmeric, that are worse than paint. In my opinion, the most important paradigm is preservation of healthy enamel. I agree with you. When finish lines are located on healthy enamel, a higher survival rate has been widely demonstrated because adhesive bond in enamel is more durable than that in dentin.
Well, I'm in line with your opinions, and my first choice would have been the juxtagingival finish line. But in this case, I made just a little misleveling with the supragingival finish line for the veneer, just because I wanted to keep all peripheral enamel, of course. And here you can see the teeth after the preparation. I refined the preparation of 1.1, just rounding the transition angles and moving a very little apically the margin of the temporary crown. And I kept all surface and peripheral enamel on 2.1, polishing the residual previous restoration that I left in situ, since less than 50% of the surface was represented by composite. And it is pretty evident our preparation for a ceramic veneer is more conservative than that for a full crown, saving about 30% of sound tooth tissues. Here is a detailed highlighting of what Professor Zarone was saying, the position of the final finish lines. Just a moment, because I need some power charging. Here I am. Okay. So, juxtagingival for the crown, coronal to the soft tissues for the veneer, and both margins are clearly visible thanks to the gingival displacement provided by the retraction cords, and this is the key issue according to me. And as during the first visit, I used the detection mode of the light curing unit just to be sure that no residual composite was present at level of the periphery of the preparation of the ceramic veneer. And now it's time to make the impression. As you all know, we can go for an analog impression making using elastomeric materials, or we can choose to use intraoral scanners to make a digital impression. And to date, intraoral scanning is precise and effective only for the details you can see clinically. So what you see is what you scan, exactly as for traditional prosthodontics. And optical impressions represent a powerful tool for our daily practice, but currently they are fully reliable only in the presence of supragingival margins. And our research group are working actively on this topic, and Professor Ferrari and Professor Zarone published this very interesting review about that. So I would like to give the floor to them just to have some hot points on this topic. Please.
Okay, thank you, Roberto. We know for sure from the literature that there is not evidence that intraoral scanner like we have at the moment, I mean, using the optical devices that any intraoral scanner has, we know that we cannot catch margin into the sulcus. That for sure. We know that. We know that the algorithm of the software, they are, I would say, inventing or making the margins, but we never know if they are realistically what we prepared. So I would say that the intraoral scanner are very effective when the prep is juxtagingival or supragingival. So they are limited to this. Or they are very effective when we use single or a couple of scan body for implants. That are the option we have in which, for sure, we can use the intraoral scan.
Okay, my opinion is exactly the same. In this case, I think it was not difficult even with a scan, but yeah, for to teeth, I will use elastomeric impression for sure.
And me? Okay, for me it's the same. I totally agree. I only need that the impression is good. Either is okay. Today there is no evidence that digital is better than analog or vice versa. In either case, controlling bleeding is paramount, and I would use a retraction cord. I agree with Marco. It's very, very hard to catch the morphology of our preparation if margins are very, very deep in the sulcus. So perhaps it's better, in that case, the analog, the conventional impression, because we can push the material inside using the different consistencies of the impression materials, while we cannot push laser or light inside a deep sulcus. One or double cord, it depends on the sulcus depth and on gingival biotype. In any case, I usually do not like any medication for gingival retraction because they can induce protein precipitation and can trigger an inflammatory reaction with subsequent gingival recession. But both techniques are okay. It depends on the height of the margins.
Well, thanks. In this case, in fact, due to the presence of a full crown with a slightly juxtagingival margin, I prefer to make a conventional impression with elastomeric materials according to your viewpoints. And this raises another question. Professor Zarone has already answered, but I want to ask to Professor Ferrari and Professor Putignano as well. What about gingival displacement? Because you know that we can use no cords, single or double retraction cord techniques, or we can choose a Teflon cord. And I would like to know more about your choice, please.
Well, when I can, if I prepare juxtagingivally or supragingivally, I go for no cord. And one cord using a suture silk, piece of a suture silk 3-0, like retraction cord, is very useful. I don't use so much the double cord technique, and I don't use the Teflon as well.
Okay, me too. In case like this, 3-0 to displace a little bit. That, in my opinion, is the best one without traumatism for the tissues. In anteriors, usually, if I have a crown, sometimes I use double cord. So I leave into the sulcus the 3-0 to avoid any kind of bleeding. I don't use any kind of product, only cord, as Professor Zarone. But in this case, my opinion, nothing where there is the crown, 3-0 is more than enough.
Well, according to me, although using a single Teflon cord with supragingival preparation is a viable option, in this case, I went for the conventional double cord technique according to the teachings of Professor Zarone, just to have a kind of consistency onto both teeth during impression making. And moreover, what about the anesthetic agents to impregnate the cords? We have so many different options, as you have already answered my questions, and I agree with your viewpoints. And I use astringent solutions in a very few cases, particularly in the presence of subgingival margins. Of course, in this case, I use non-impregnated cords because we are not inside the gingiva. And according to the literature, it is possible to use both the single or double retraction cord technique. The only important thing besides the technique you choose is to expose clearly the preparation margin, so as to allow the impression materials to penetrate into the gingival sulcus and overextend the impression. And I'm used to make one-step impression with elastomeric materials and different consistencies, in this case, medium and light polyheders, as you can see. Then I made a bite registration with an addition silicone. And here you can see a close-up of the impression. But I'm tricking, I'm showing you a misleading image, because this was the real situation after impression making. Maybe due to the rigidity of the polyheders, the old composite restoration broke down, and I wrongly trusted its clinical aspect after polishing, and I got such a pitfall. So how to manage this technical complication right now? We can do nothing asking the dental technician to compensate with ceramics. It is possible to remake the impression with or without rebuilding the composite restoration, or we can go for reattachment of the fragment. Of course,
it would have been not to have any fracture. But in this case, Professor, how can you manage this situation? Professor Ferrari.
Well, maybe I remake the impression just easily and see what happened, if I can catch a good impression.
Professor Putignano?
I retouch the fragment and I remake the impression, because even if you are the strongest in the world to retouch the fragment, in my opinion, the position or a little bit of bonding or something could happen and change something. So don't forget that is in the tooth that you will put a veneer, no? If it's correct, is the 2.1. So I retouch and then I remake the impression in a few minutes, no problem.
Professor Zarone?
This is like the gender of angels, in my opinion. There is no one way to solve this problem, not just one way. All of the proposed solutions, in my opinion, are likely to be successful, provided the macroscopic quality of the composite fragment is acceptable. In my opinion, it was not a complication. It was a gift from heaven for you, because that composite would go away probably after 1 month, 2 months, or 1 year. The only thing I would do, if I went for the reattachment of the fragment, I would make a new impression. We have to consider that you decided to make a veneer, so we don't want any discrepancy to impair our job. So probably reattachment, but with a new impression, or leaving, as Marco said, leaving the things like they are. But you need a very, very skilled technician, because you have to remake in the core of the silicate or whatever else. You have to reproduce color and shape in a very, very difficult way. So probably reattachment. I would go for the reattachment and new impression.
Well, you know me, you have been known me for many years. You know I'm a Neapolitan lazy guy, but I completely trust in adhesion. So I decided to reattach the fragments, and I cleaned up thoroughly both surfaces and used a conventional etch and rinse adhesive technique to repair the broken piece, just like this kintsugi art from the Japanese art of precious cars, crossing my fingers. And then I used the silicone template of the mock-up, as Professor Ferrari has anticipated, to fabricate a couple of direct temporary restorations joined together, so as to strengthen the very thin shell of the provisional veneer by means of a connector, and reducing the risk of the cementation until the final prostheses were made. Of course, after complete setting of the bisecretic resin, the direct temporaries were finished and polished extraorally, with particular care for the margins, in order not to interfere with the healing of soft tissues that had to recover from the slight impression trauma. And as a consequence, the interdental spaces were left wide open to allow creeping and maturation of the gingivas. And about 15 minutes after the final impression, although the tissues are still a little injured, you can appreciate the different levels of the two finished lines. Then a quick but careful occlusal check to control the presence of extended contact areas and sliding surfaces to guarantee stability to the provisionals. And as you can see from the lateral incisors, the patient was still smoking pretty much. The master casts were powered in extra hard dental stone, and all the details of tooth preparations were clearly visible, transferring all the clinical information to the dental lab. And of course, the selection of restorative materials has to be done at the moment of treatment planning. But for discussion purposes today, I guess that this is the right moment to make our materials choice. And when selecting restorative materials, clinicians are requested to operate an informed choice, taking into careful consideration all the clinical variables affecting the case. It is necessary to assess the type of restoration, the areas to be treated, the quality of dental substrates, the patient's requests, and last but not least, as my master has taught me over years, the occlusal scheme and the stability over time.
Then it is necessary to select the restorative materials, assessing the wide and up-to-date scenario of dental ceramics, according to their specific properties and to the clinical needs of each single case, profiting by the different optical and mechanical characteristics of each material. And I would ask to our special guests, what would be their choice in this case? Please, Professor Ferrari.
Well, yes, I would go for feldspathic or for lithium disilicate. So probably I would go for lithium disilicate because there is a full crown. And so the full crown prep will push me to go for lithium disilicate. In that case, I should go also for the lamina veneer in lithium disilicate because I want to have same material in two teeth close each other.
Professor Putignano?
In my opinion, the same exactly as Marco in this case because of the choice. Because in my opinion, if you choose to go for a crown in the 1.1, I should go for the same in the 2.1. No reason. You have this kind of composite. Why not another crown there? I'm a very conservative guy, but in this case, if you choose for the crown, in my opinion, it's better to go for two crowns. At the end, you have the provisional restoration that are separate. You can manage the tissue in another way. At the end of the story, even if you have not so, have you seen that you have the detachment of the fragment? In the future, probably will be more protected in this sense. I will not to have a problem with my patients after I finish my restoration. So I guarantee all my restoration for 5 years. And after that, I want to be frank with you. Since I start to do this, everything is good because when I think what I have to do, I think what could happen. That's my opinion. But after that, my opinion, lithium disilicate, in this case, absolutely your choice, is the best material because feldspathic for the crown, yes, it's good. But, today you have a good technician, the lithium disilicate is a good material.
Professor Zarone?
We lost Professor Zarone.
We lost Professor Zarone, so Roberto, let's go on and let's try to connect Professor Zarone again.
Okay. Well, for sure it would be necessary much more time to discuss this topic, but we don't have enough. So I would like to refer those who are interested in going deeper to this recent review we published a few months ago in BMC Oral Health. And my personal decision-making process for materials choice was the following. I had to treat the patient with single restorations in the maxillary anterior area, so in a very aesthetic area. I could profit by a huge amount of enamel. The patient's demand was mainly an aesthetic improvement of the smile, but the occlusion was quite risky because even if I had enough occlusal room after the preparation, there was a significant involvement of the incisal margins during protrusion. So I ended up, and I completely agree with you, with lithium disilicate to combine both the optical and aesthetic advantages of such material. And of course, it would be possible to use different dental ceramics for crowns and veneers, but I completely agree with Professor Putignano, and in my personal experience, and also according to the most recent literature, it is always preferable to uniform the materials of the restorations functioning together. And moreover, lithium disilicate prosthesis can be removed from the master cast to perform an intraoral try-in, a color check, and any possible correction before final finishing and polishing. And as you all know, this is not possible, for example, with feldspathic veneers. The details of the master cast show the optimal precision and marginal fit of the lithium disilicate restoration. These were pressed restorations fabricated by Mr. Vincenzo Mutone. And the crystalline properties of the material allow to extol the translucency and opalescence, achieving a very natural tooth-like appearance of the restorations, keeping at the same time excellent mechanical properties. And 2 weeks after the final impression, the recovery of the soft tissues was very satisfactory thanks to the precision of the temporary prosthesis that made possible a correct stabilization of the gingivas and filling of the interdental papillas, as you can see. And here you can appreciate the healing of the soft tissues at high magnification with the good color and shapes of the soft tissues,
showing the ideal features for the subsequent cementation of the restorations. And
Roberto, I'm back because I lost something. Something happened and I lost my connection.
Yes, we lost you for a while, Prof.
Choice of material. Your material.
Well, I went for lithium disilicate on both the crown and the veneer.
Okay. Bi-layer, naturally.
Of course, by layer, yes.
Okay.
Pressed and by layer.
I don't know what happened, but I lost your connection, so I'm back.
Okay. Then, even after preparation, according to me, it's mandatory to check the achievement of the correct prosthetic room by means of a careful static and dynamic analysis of function, both in centric occlusion and in non-axial mandibular movements. And let's now move to another hot topic, the cementation. When we have to make a decision between luting and bonding, we do not have to consider the luting agent by itself, but we have to take a step back, selecting the cement on the basis of the chosen restorative materials and more generally on the clinical situation in its entirety. So we have to make an informed choice among conventional adhesive and simplified adhesive cementation techniques, namely the self-adhesive resin cements. And professors, according to the variables of this case, I would like to hear your advices, knowing that this is a very wide and huge scenario and we would need 3 hours to discuss it in detail. But I would like to ask your opinion. Please, Professor Ferrari.
Yes, thank you. To me, I would go for adhesive luting material. So bonding and luting with bonding system and a luting material, dual cure resin cement. That because in literature it seems to be that is the most reliable for lithium disilicate. And then also during the luting procedure, I can control what I'm doing. And so I would not go for glass ionomer. I would not go for simplify adhesive self-adhesive resin cement.
Okay.
Professor Putignano?
I totally agree about the cementation, not dual cure, probably photo curing, because even for the preparation of the crowns is to be not so thick. So you have to extend a little bit the time of polymerization. But we have not to forget that for this, we need to put rubber down. I want to be frank with you. So the general practitioner, they don't love. Still the 10-15% of the dentists all over the world, they use mostly in endo and less in resto and prosto. So it means that probably the self-adhesive cementation even is not the best. Even is not the best. For some people that they are not able to manage adhesion in the right way, and you know that you have a lot of things adhesively using air blow, what the thickness of the bonding that you use, if you have to cure or not. So if you want to open discussion, I think that we need at least 3 or 4 hours about this topic. But overall, is the cement, composite cement, light curing, in my opinion, because you have all the time to remove excess, to check the position, to check everything. So that's my opinion.
Thanks. Professor Zarone?
Naturally, classic adhesive cementation. I would go for dual cure, but it's the same. After using trying paste with a very approximately trial of shade, just 20 seconds of hydrofluoric acid in the entire, then distilled water in ultrasonic bath, and everything is okay. Avoiding overetching of the entire with longer exposure to strong acid, because it can induce damages, and so that's a very, very important step, etching the ceramic, but naturally adhesion, naturally with rubber. That's paramount.
I prefer to sandblast before the enamel, if I have enamel today.
Yeah,
I prefer to sandblast before the etching.
Can be.
Prof, do you use the AquaCare solution for sandblasting or traditional powders?
I use AquaCare.
AquaCare, perfect.
Or Rondoflex by Cavo is the same, so underwater. So in this way, you are more precise, you don't spread, but even if I am under rubber dam, no problem. But after that, for the environment, it's better to use the water.
Angelo, with the silicate, you have to be very, very mild with sandblasting.
I was telling about the enamel.
Plastic, I only etch the lithium disilicate. What I mean with sandblasting is on the tooth, not on the restoration.
Okay.
It's coming from the lab, only sandblasted.
Okay, perfect.
Professor Putignano, I was asking you about AquaCare because nowadays it's my first solution as well. The case of 3 years ago, and so you will see a traditional etch and rinse technique, but I completely agree with you that this is the mildest kind of sandblasting enamel to optimize the adhesion. Anyway, thanks for these cues. And in this case, according to we all, the choice is very simple because due to the high silica content of the lithium disilicate, the adhesive approach is mandatory, both to guarantee retention to the veneer and to strengthen both the restoration with the creation of an adhesive monoblock. And of course, as you have anticipated, it is necessary to condition the ceramic surface before proceeding to the clinical steps of cementation. And briefly, this is another very hot topic. We can summarize the lithium disilicate conditioning into 3 steps. Hydrofluoric acid etching for 20 seconds.
5%.
Yes, 5%. We can, you know that in the US they are using 9%, but there is, there are so many evidences that
yellow is the 10. No, usually it's the red that is 5, but it's the same. If you use the 10, you have to reduce a little bit the time, in my opinion.
Perfect, exactly. Usually I prefer to use 5% just because of the thickness of the restoration. If you are under 1 millimeter, I prefer to use 5% hydrofluoric acid. Then you have to clean the surface by means of dedicated cleaning solutions, surfactants, or degreasing with 90%, 96% ethanol. And finally, the application of coupling agents, just like the MDP-containing primers or silanes, according to the resin cement you are going to use. And it is well known, as you have anticipated, that the achievement of good adhesion relies on the management of clean surfaces. And in this perspective, the isolation by means of the rubber dam is mandatory to prevent any contact with blood, saliva, and other contaminating agents. And the careful control of moisture is an indispensable prerequisite to obtain the best bone strength that can be reduced up to the half in the presence of contaminants. And here you can see the try-in of the restorations. Well, as regards the cementation of the veneer, since it has no primary retention for definition and all preparation periphery was kept into enamel, I chose a conventional 3-step total etch approach with a universal adhesive system and an aesthetic resin cement, namely a dual curing resin cement, so as to avoid marginal discoloration over time. And I do not like to use either burrs or metal tips to finish the margins, but I carefully clean them up by means of urethane dimetrichloride curettes, not to remove the ceramic glaze. And once again, the fluorescent light could be helpful in identifying possible cement excess. Differently, I used a simplified adhesive protocol with a self-etch approach for the crown, since it had good primary retention. And although complete isolation is not mandatory when you go for simplified cementation of full coverage crowns, the use of rubber dam makes cementation faster, easier, and much more precise. However, it's just my advice. When you use self-adhesive cements, remember to protect carefully the adjacent teeth with Teflon tapes or with transparent matrices. Otherwise, you can waste a lot of time in removing cement excess from the interdental spaces by means of blades or finishing burrs. And this is the immediate post-cementation view. I always use very thin 3-0 retraction cords, silk cords, to prevent the entanglement of resin remnants under the gingivas. Very gambling if you are dealing with self-adhesive cements. And finally, I perform post-curing with an oxygen barrier just after freeing the gingival margins completely.
And cementation is always a little bloody for soft tissues, but this is just an acute injury, and waiting for a couple of weeks, the aesthetic and biologic integration of the lithium disilicate restorations was satisfactory, with the natural tooth-like appearance of the prosthesis and complete healing of the gingivas, as we have reported in these publications. For this purpose, I always ask the dental lab to leave unglazed the margins of the lithium disilicate restorations, as its biocompatibility has been proven by several studies and by our research group as well. And an excellent biointegration is achievable, as evidenced by the optimal healthy condition of the gingivas at high magnifications, confirming that the cementation was managed correctly. And although aesthetics is very important for patients and the primary goal for most dentists, I'm mainly a prosthodontist, and for me reliability means proper function and correct occlusion. So the real clinical success is represented by these images showing the precise reproduction of the occlusal schemes designed in the articulator. So stable centric contacts and wide areas for the sliding movements that represent reliable insurance for the structural integrity of the ceramics over time. And restoration show good integration in the display area of the smile, proper emergence profiles, correct dominance, considering the gender and the young age of the patient. And this last slide, you can appreciate the comparison between the preoperative situation and the 3-year follow-up recall. Healthy and stable soft tissues, a good integration of the lithium disilicate prosthesis within the residual dentition of the patient that was satisfied as much as I was. For sure, today I will make some little differences in my clinical steps, but I can be, I guess, satisfied with this result. Well, the case presentation is over, and we can answer a few questions that you can post on social channels, specifying your country of residence, and that will be selected by our technical support. In the meanwhile, professors, would you like to point out some issues and take-home message for today's speech?
Okay. Yeah, I would like to kindly ask you, Roberto, you use also the 000 suture silk as a retraction cord during the cementation procedure. Yeah. Did you have ever any problem on doing that, or what can be the advantages to use it?
Well, it happened a couple of times when I was much younger, unfortunately, and always with very thin gingival biotypes and for multiple restorations. That's why today I select the retraction cord according to the biotype and according to the number of restoration, because I don't want to use the full rubber dam for more than 45 minutes. So sometimes I go for Teflon tape cords and for the split dam technique as well. But usually I go for this kind of 3-0 very thin cords just to prevent the entanglement of resin cements under the gingivas.
That's the advantage of the digital procedure, because you can take an impression in a modular way, one after the other. So you have not to leave the retraction cords for a longer time.
Okay, but in the cementation, I totally agree. I would like to emphasize 2 points that probably we miss. For example, when I treat lithium disilicate, I use it to re-etch with the phosphoric acid for 60 seconds, using the Daniel Lidloff techniques, because you know, the ultrasonic bath is not in my room. Is in the sterilization. I will not that is small crowns and veneers. They go with my nurse into another part. That's why I prefer to react with the phosphoric acid for 60 seconds. And for the cementation, I totally agree, one by one. The only things that I do different, I prefer to finish completely my polymerization, putting glycerin or something to avoid the oxygen inhibition layer, because in the way that you do, you have the blood that immediately could go into the margin. If you is porous and not well polymerized, probably you could have some problems. It's only a small difference, but I totally agree. In the way I go one by one, to do not have the rubber down for 1 hour, 1 hour and a half. If you have 10 restoration to bond, is from the second upper to the other second upper premolar, for example, when you make 10 veneers simultaneously.
Well, thanks, Prof. I agree with you. Of course, I showed just the posturing. I used the oxygen barrier also before removing, after the inspection of the margins under the rubber dam. Then I removed my and I perform the posturing.
Roberto, there is a question.
Yeah.
For veneer, why proximally prepared? I read on the screen, on the right. Why you prepared proximally?
Well, according to me, there are several reasons. So first of all, if you want to reshape the interproximal contour, you have to prepare very little the interproximal spaces. Okay, here we are. Okay, sorry. And usually I use just the stripping burrs on a sonic handpiece, so 0.3 preparation. The second reason is to manage more easily the cementation, because if you are exactly interproximal, you can have the block in the undercuts of the natural anatomy, not of the preparation, of course, little cement remnants. And the third point is because of a strategical placement of the margins of the restorations. I always prefer to put them in non-visible areas, in particular in cases just like this in which the patient is a smoker, because I don't want to have any kind of peripheral discoloration over time. I don't know if you agree or you want to add something.
Absolutely.
I agree. If you have the line that is not similar to the other one, in the middle you can see some brown area, and you don't know if it's because the change of the color of the tooth, or if the line of the proximal line is better to prepare a little bit, and you manage the space in the right way. So in this case, it's very simple. In this case,
there is another interesting question: how time you etch feldspathic ceramic? No, with phosphoric acid. No, with hydrofluoric.
No, I told that I used to re-etch the ceramic with the phosphoric acid to avoid the passage into the ultrasonic bath. So
sometimes it can be not advisable. I read something that the use of phosphoric acid just to clean the surface is not advisable too much.
If I can add just a little point, there is a very interesting paper by Murillo Gomez on dental materials in 2018, I guess. I showed the reference during the presentation, and they deeply discussed this point, because the use of phosphoric acid just for cleaning is advised by most clinicians, but there are a few lab evidences that it could be a little detrimental, but it's a very common clinical practice as well, to remove the possible little remnants after degrading. So that is point of Professor Putignano.
First.
Yeah. And Professor, sorry, I guess because I cannot see the question, how long, the question was how long the etching with phosphoric acid, correct?
Yeah, but that's not for etching, that's for cleaning. Just for cleaning.
Just for cleaning, sorry.
Okay.
Well, anyway, usually 20 seconds are enough, according to the literature, to clean the surface, not to etch it, of course.
There is a very interesting question. If it's forbidden to put a margin over the composite.
Wasn't placing
over the composite. Well,
in this case, not. In your case, not, but it's a very good question.
Yes, we have to open another big chapter, and I would like to get the floor to Professor Ferrari, because we are in between the discussion about the cervical marginal relocation. It's almost the same. So, Professor Ferrari, we had together, but you was the proposer of a very beautiful project on this topic. So, it's up to you.
Okay, I feel that the problem is not if we have resin composite in the margin at the moment, looking the quality of bonding materials and resin composite material we have at the moment in the market, but is the position of the the deepest, the most apical part of the margin of the raising composite, the position from the bone crest. So the point is, we need to respect and not to interfere on the connective tissue attachment, and we need to leave the possibility to the patient to clean that area. So using an old definition, we need to respect the biological width. If we do that, posteriorly, we can make cervical margin relocation, and accordingly with the case, the need of the patient, the aesthetic purpose, and the skill and knowledge of the operator. So why not in a class 5 just to place a margin? Because if we do in class 2, we should do in class 5, theoretically. Unfortunately, what happened is that dentists, they much love to place cervical margin relocation on posterior area, but they don't want to do buccally in class 5. So we have to think a little bit. Personally, I do not believe that cervical margin relocation is so useful as is presented at the moment in the dental field. But in some cases is indicated. Angelo?
Okay, I don't think to put a margin of the veneer over the composite. In my opinion, class 5 restoration is another story of the class 2 restoration, because the margin usually is not so predictable, because is under CJ junction, but don't forget that you never push the material over this margin. When you do class 5 restoration, if we follow what the V-shape cavities, you have to put before the material over the margin. You work in the hair. So if you don't push the material, you will see all the time white lines. And at the end of the story, these white lines, that's why I totally changed my way to do class 5 restoration. Even, I read a lot of papers. After that, I prefer to close as the last part of class 5, just the margin, pressing a lot of the material. Since we do in our team this kind of technique, we never see a white margin in the class 5 restoration. So if I can avoid to put a margin of veneer over the composite, because if allow me to go for the composite just in the margin, is the same for the ceramic margin. In posterior is a little bit different, because sometimes with the matrix allow you to catch the margin in a nice way, but not to manage a prosthetic margin in that area. That's why to relocate the margin, but the literature in this moment is not so full of references. There are a lot of auto references in this, but if you believe and you trust in adhesion, why not to trust in a margin over the composite? If you can avoid, for sure. But sometimes it is a compromise, treatment plan that I often do in my daily job.
It's very controversial, and there's no in the literature. Absolutely, I agree.
Well, anyway, it's nice to see that we have sometimes different approach.
Yeah,
of course.
But we do the same things, I know.
Yeah, absolutely. Okay, there are other questions that they arrive from the web, and one is pretty interested. How to scan with rubber dam on? Roberto.
Check the occlusion after that.
That's a very good point. Well, you can scan just if you are a lot outside of the gingiva, and in my humble opinion, of course. And just if you want to scan one restoration or a couple of restorations, but you have to manage many different problems, because as you know, the tension of the rubber dam is one of the main obstacles to moving at level of the gingiva, at level of the margin, the tip of the intraoral scan. And you have to manage as well the scattering back of the metal or of the shiny surfaces of dental clamps. That's why we are trying with Professor Zarone some little tips, just like black matrices, anodized metals, just to not to have this kind of reflection. But it's anything completely anecdotal right now, anything scientific.
There are some other interesting questions, as it's possible not to etch the zirconia. I know that you all are studying a lot about this field, so it's very interesting.
Well,
who is going to answer?
I'm just a pupil, so.
Okay, there is a lot of discussion about that because there is a little bit confusion about definition of zirconia. Somebody classifies zirconia like a ceramic, porcelain material, ceramic material because it's white. Zirconia is a zirconium oxide, is a metal oxide, and is much, much stronger than any porcelain material. So we have tried to age zirconia and to age zirconia. And when I say age, to create an age pattern on the surface in order to increase the surface retention due to the penetration of resin into some deep parts that were created. So we have to use the same etching solution that we use in the 80 to etch chrome cobalt alloy in order to bond Maryland bridge. And this kind of etching solution is very dangerous, is not allowed to keep in the office. So it's something, and also it's very dangerous to keep in the lab. So it's not available anymore. It's something that is done chemically in some chemical institution in the lab, but is not for dentists. So for that,
you use the Polytechnic silane with 10 MDP.
Exactly. So, and for that, we cannot etch, but we can bond, and that is another issue. So we have to use a proper word in order to explain. So we can sandblast, and then we can use MDP as a chemical sealant. And Professor Kern, Matthias Kern from Germany has really a lot of data on that with great success clinically. So anyway, to me, zirconia is the best material to make a monolithic crown posteriorly and to make porcelain fused to zirconia full crown in anterior teeth. If you want, you can also etch, and you can also make partial crowns, but using sandblasting and MDP.
You can etch ZLS, zirconia reinforced lithium silicate, but that's another.
Is another material.
Different material. So
yeah, it's a different material.
Okay.
I did a lot of single retainer in lateral agenesia with the zirconia. I never added the bonding, so I did only 15, but is after 5 years, it works very well.
There is another question.
Yeah. There's a question
about the okay, you can see Roberto, so you can read.
Yes, just because there's a colleague, I guess, from Turkey that is asking about the color picking. And in this case, I just made a traditional color picking with a traditional shade guide and pictures. But I guess that Professor Putignano can tell us a lot about the digital color picking, correct?
Yes, in the next future, you will see appearing in the market a new machine that is unbelievable, because there's an error that is 0.1, 0.2. It means that is the perfect color. And the same machine probably in the future will allow you to give even the recipes for the ceramic, what to do to get perfectly the color. And the shade guide that you use is your shade guide that you put inside the machine. After that, if you work with your laboratory, it will be very easier to check the color, because all the spectrophotometer, in the past, they didn't have a lot of success because they didn't work very well. And till now, only one, I think, is available in the market, because all the other, they stop to produce. The color is a number. It's not an art as a lot of people they want to show. They are artists because they are able to create a sort of, a vision about the color, but the color is a number. If you are able to repeat the number, the color will be perfect. So that's the problem, that sometimes we work as artists, but we have to leave aside, in my opinion, today, because we have new materials, new tools, and to work a little bit more scientifically, and not only because of our skill. No, I cannot transfer the skill. The only thing that I can transfer is the knowledge, it's not the skill. So that's why, in my opinion, the color is one of the topic more difficult. No,
I would like to add something, Angelo. I would like to add something on top of your statement, because I completely agree with you. But I believe that there are 10% of dentists, they have hands as artists, but 90% of dentists they don't have, but they make a great job anyway, because training themselves, they can do a very good job. So to be artists, to have a talent can help a lot at the beginning, but with good training, any dentist can do the best job.
I want not to be a performer. I want to be a good dentist.
Yeah, exactly. Roberto, there is a question mainly for you, because you did the job. Why you didn't cement with heated composite, and what material you recommend?
Sorry, I didn't catch. I had the problem with the audio. What was
why you did not cement with heated composite, and what material you recommend?
With the classic composite, film composite.
Yeah, okay, that's just because in my hands, I prefer to use dedicated cements for anterior side with tri-in pestis, water-soluble tri-in pestis, particularly when I deal with very thin restorations. You can go for heated composites as well, but you cannot check the color. So it's just my opinion, it's just my way of working for more than 20 years. And I prefer to test the color with the tri-in pestis for veneers. Although there are so many evidences right now that tell that if you're going for lithium disilicate veneers up to 1 millimeter, the influence of the underlying resin cement is not very important. In this case, the veneer was not so thick, so I prefer to use the traditional aesthetic resin cements.
Which is the reason to use a preheated composite in anteriors. In my opinion, it's totally stupid. There is nothing more. The new cement, they are filled in weight 81, 82%. That is more than the composite that we use for direct restoration. So there is no reason in anteriors. People cement since 40 years with the normal cement that was not so powerful as the new one today. There is no reason. You cannot control. You start for 50 degrees. When you arrive on the surface, you are 37 until you press and you check and you cure. You will have the same temperature and you will break very easily. So not the lithium disilicate, but if you use feldspathic ceramics, it's almost impossible.
Yeah. In fact, at our department, Professor Zarone, we had over, I guess, 15 years, 2 cases of one tri-in fracture and 1 post-cementation fracture because of the high contraction of the contraction ratio, the shrinkage after the polymerization, correct?
Shrinkage, yeah.
I think Professor Zarone is very proud of you, Roberto.
Absolutely.
Because I usually break the restorations and he can remake very nice.
Hey, do this. I have a consideration, Roberto. It could be the final consideration about the slide that you showed about success and prognosis, 100% operator related.
Yeah.
One of the first ones. I would like to say that treatment plan has to be focused on different factors, as you pointed very well. Some of the factors are under our control, like restoration design, clinical steps, choice of materials, typology of cementation. We have seen this, just to name a few. But other factors are 100% dependent on the patient and out of our control. For instance, functional, parafunctional loads, compliance, and hygienic dependability, not to mention psychological response to the treatment. That, unfortunately, I believe that from now on will be more and more pernicious, I think. So from the moment of cementation on, a large component of success is left to the patient himself, isn't it?
Yes, definitely it is. In fact, the slide was just referring to the treatment planning. But of course, I remember a very nice sentence by Dr. Fear, is the American dentist who taught about for the first time about self-adhesive materials. And he thought that the day of cementation was the last good day for the dentist, because from that moment till the future, everything was in the hand of the patient. So it's made up of the compliance of the patient, the hygienic maintenance, and so on. So there are so many patient-related variables as well. I completely agree, yeah.
There is a very good question for Marco. Marco, do you recommend fiber post build up?
We can organize another webinar on that. But anyway, just answering very, very briefly, do you recommend fiber post build up for all endodontic treated cases? We do not. There are cases in which fiber post is very useful. We have other cases in which fiber post is not useful. We can avoid to place it. So depend the single case, depend the situation, depend the root anatomy, depend the coronal anatomy, how much coronal structure remained, what material we want to use, what tooth we are treating. So we can make another webinar, maybe.
I'm about to cry because it was my PhD thesis. So
I know, but I want to.
It's like 15 years ago.
There is another.
Anyway, it's still actual because it's still a topic that is very hot at the moment. And well, maybe we can discuss another time because we may need a couple of hours at least.
There is another current question that is the way that we use AquaCare, Roberto. Okay. I want to explain mine. For sandblast enamel, I use the sandblast with 28 microns coarse particle. Even I sandblast with a 50, and that's all. You have a different powder disposition to clean, to sandblast, to cut, what you like, because the machine is really unbelievable in the performance. You have to change only the pressure for the machine, because you are 2.5 atmosphere or 4 atmosphere or less atmosphere. It depends on the powder that you use. I don't know, Roberto, if you want to add something about AquaCare. No.
I'm in line with you because usually I go for 28 microns particles, and I go for no more than 1.5 atmospheres, usually, to do just the sandblasting of enamel. If you want to use it, for example, on dentin, it's a little different. If you want to use it to remove discoloration, you can go for higher pressures. But I'm in line with the user's manual, so 1.5 atmospheres and 28 microns.
Great.
I'm moving my head because I have the questions here.
Another question.
There's a question about posterior bridges in general. Well, this is a completely different chapter. Professor Zarone, would you like to add something about posterior bridges?
I think that there is no panacea, no one material for every situation. Zirconia, of course, in the posterior bridges is our first choice. We are going increasingly toward monolithic zirconia, painted. To avoid chipping. We had a lot of chippings in the past, and that's the only material we use for posterior bridges. Old bridges made of disilicate gave bad results on the medium or long term. There is a lot of literature about this. That's what we do. Frontal, you have veneers and or single crowns. No difference. It's a matter of occlusion. You have just to protect posterior and everything works. If we respect occlusion, these materials work very, very in a favorable way. Zirconia ceramic fused, yes, we had a lot of chipping problems. We have published a prospective study. Now we are going to publish the 11, Roberto.
14 years. 14 years.
14 already?
14, yeah.
Okay. Time passes by. And 14 years follow up, and we had more than 6% of complications about this.
Another question is if you use all the time immediate dentinal sealing.
Well, I don't. I use IDS only in deep cavities in posterior, also because when I go for ceramic veneers on anterior, usually I try to keep all the enamel, of course, or I made very little composite build-ups if I need. In posterior areas, I use IDS only in case of postoperative sensitivity, so in case of very deep cavities. And if I go for IDS, I always try to reactivate the bonding, in this case, a universal adhesives with mild sandblasting or with a second coating of universal adhesive after the temporarization. Because, of course, if you prepare an inlay or an onlay and you put your temporary material on top, you have a kind of contamination during the 2 days, 5 days, or 7 days necessary to the lab to make the final restoration. If you go for something chair side, maybe it could be different, and you can go for IDS routinely. But it's just an opinion because I do not use chair side appliances.
Well, totally agree with you. Same.
I would like to spend a few words about IDS, just to explain to the people that are listeners that IDS is nothing new. Nothing new. It's something that just means just to bond to dentin, nothing else. So in any case in which we go for build up, and then in order to build up, firstly we bond, we are making IDS, nothing else. So it's something that is older than 30 years, and somebody called it like a new technique, but realistically, when we bond, we do IDS.
I guess that you described in your PhD thesis this technique.
Yeah,
for the
yes,
first
in 95, exactly. But after that, if we want to talk about IDS as a prevention of post-op sensitivity, okay, that is another issue. And if we do that, please place on top a very thin layer of flowball in order to completely seal the dentin, because if you do bonding with an universal material, we know that all of them act as semi-permeable membranes, so they don't seal. In order to seal, we have to apply on top or unfilled bonding resin, or we have to apply a small amount of flowball, nothing else.
In the front, it doesn't make sense because you work on enamel.
Yeah, of course. We are talking denting, not in enamel.
Where? In the front?
No. We are talking now for IDS is for denting, just for denting.
It was introduced for the posterior cavities.
Yeah, sure. Any other questions?
I guess there are thousands, but we have to cut it off.
Excuse me, Roberto, one that can be very interesting is in order that you can touch how you remove excess of cement, because they are asking if you use a dental floss to remove some excess cement. My question, a little bit wider, is how you remove cement excess when you lose.
Okay, yes.
And how you like cure. Just describe a little bit.
Okay. I moved pretty quick on the slides because I had not enough time. Anyway, usually I complete the sealing of my restoration. I use a brush or a micro brush moving from the ceramic toward the dental tissues and not in the other direction. Otherwise, you are going to open the micro gap, so from the ceramic to the tooth. And after removing the main excesses, I apply a jellification protocol. So it depends on the wave power of your light curing unit and on the kind of cement. Usually I use a 1400 milliwatt light curing lamp. So I use 3 to 5 seconds according to the kind of cement I use. 5 seconds for light curing and 3 seconds for dual curing. Then I floss the interproximal spaces, or I use the Teflon tapes, the interproximal Teflon tapes, just like a quartz, to remove the excess from the interproximal spaces. And then I carefully inspect the margins with the yellow tip you have seen in the pictures. So it's a urethane dimethacrylate curette, very gentle, and it is useful not to remove the glaze from the ceramic restorations.
My opinion is better to use the tape, because if you use the floss that is too thin, if it's not set it very well, you can enter into the margin. That's the problem. Yeah. That's why it's better to use the tape. And the other, if with a lithium disilicate, really you don't touch, but you can touch, because you can polish in the right way. So, you know, today a lot of technicians, they prefer to polish instead to glaze. So you need to have a kit of the same instruments that your technician used to polish, to repolish in the mouth. In this way, you can leave a little bit of material, a little bit of in excess, in my opinion, avoiding any kind of, you know, some deficit that in the past I saw in some of my cases after years that probably don't influence the long-term result, but it's better that everything is well sealed, in my opinion.
So you make a conventional finishing and polishing of the restoration margin, correct?
Yes. Yeah.
And Prof, what kind of powder you use? What kind of paste you use?
What kind of?
What kind of cleaning paste you use? A diamond paste?
Over the restoration?
Yes, at level of the margin to make this kind of polishing.
You have some rubber diamond points expressly designed for lithium disilicate or for zirconia, different kits. And at the end of the story, if you want, you can use diamond paste, but it's not so predictable, in my opinion, because you are in the margin. So you put the paste, you don't know what happened. I want not to be dirty in that, you know.
Okay, Roberto, there is time at least for one question more. When you assess the occlusion, the function, during the process of movement and after cementation, do you have the same adjustment protocol regarding veneer or a full crown? And which articulating paper thickness you choose for this, like Aquafil?
Well, this is a very good question. Usually when I make the try-in of the restorations, I use both 25 microns and 10 microns paper foils. After the cementation, I do perform my occlusal check, finishing and polishing. Sorry, but I don't trust people saying that after the cementation under the rubber dam, everything is perfect, because you know that you can have any kind of little movement due to cementation. And so I perform my finishing and polishing with red diamond burrs. And as Professor Putignano said, I use diamond passes at 25 microns up to 80 microns according to the material. So in case of feldspathic or lithium disilicates, I use rubber points with 25 microns diamond paste, and I raise the microns, the diameter of the particles, up to 80 microns if I have to polish monolithic zirconia. And I raise the microns. I don't know if you agree with this protocol.
Yeah, I completely agree. Of
course.
Sure.
Professor Zarone, do you agree?
Of course.
Well, I guess that we are at least at 2 hours. I just want to spend 30 seconds to show you a couple of projects we have and to greet everyone. And I would ask all people that are following this session to go on writing and contacting us. And I would like to ask our technical support to show the slides, please. Ciro, the slide of the presentation is possible?
Not me, but the slides.
Yeah, you are very handsome, Prof, but I need the slides now. I think there's any little problem. You don't see the slide, correct, right now?
No. But we have another question. Why we don't use normal flowable composite for cementation? So is there exactly that you use a cement, but you cannot try the color?
Yes, definitely.
Personally, I prefer to use, for example, an A3 in the margin and A1 inside my veneer. If I have to put different veneers, for sure, 6 veneers, not only one veneer. In this way, you blend a little bit the color, because sometimes the veneers are a little bit too monochromatic. Overall, if you go for, painted or something like this. But
Angelo, we never use transparent or clear, because they can lower the value, the shade value.
That's the color at A3 or A1, not transparent, because you reduce the value. And the lithium disilicate after the cementation, you know that is terrible with the value.
Okay.
Okay, I guess we are okay with the slides. So just before saying goodbye, let me show you a little teaser regarding the 2 newest projects from our Zerodonto group. First of all, My Zerodonto is a kind of automatic blog where everyone can upload and share his own clinical cases, having the maximum visibility on our social channels. And in this way, we try to create a huge database where clinical cases could be easily searched and called back by branch, material, or technique, or author, whatever you want, without getting lost, just like in Facebook or Instagram. And then we have just opened Zerodonto Academy. It's a web box where it is possible to upload, share, and search meeting courses and webinars from all over the world. And I hope that Professor Ferrari, Professor Zarone, Professor Putignano will share their own courses on our webpage. The tool is user-friendly, very quick. You can stay tuned with educational activities worldwide. And as in all our platforms, everything is completely free. So the time is up, but once again, I would like to thank you all for being here today. Moreover, I would like to express all my gratitude to my masters, the very special chairman of today, Professor Ferrari, Professor Putignano, and Professor Zarone, to share knowledge, liven up this session with their very punctual participation. I really hope that our speech could be useful for your clinical and e-learning activities. And in this slide, you can find our Instagram professional profile. So feel free to contact us for any further need and to stay tuned with our next events. Let's hope that the social distancing will end up as soon as possible, and otherwise we will meet online again. So thank you very much for your kind attention, and I would like to invite the professors just to say goodbye to our colleagues from the live webinar. Please.
It was a pleasure. Thank you so much. Thank you, Roberto. Thank you, Angelo and Nando. And thank you to all the people that they love to stay with us. Thank you.
Thank you, Roberto, for inviting us. I want to thank you even from our group, Style Italiano. And a very interesting meeting, a little bit different than the others, but the questions were really very focused on the topic. And also thanks to the audience for their question, really very interesting question. I saw we had people from all over the world, Indonesia, Taiwan, Australia, New Zealand, South Africa. So it means that we did a good job. Thanks. Ciao, Roberto.
And
Ciao. Really a great experience.
Thank you so much for joining us, and see you.
So thank you very much to everybody for your kind attention. Good evening or good morning, good night, according to the time zone. And we promise to make some new joint ventures with the Style Italiano group and with the University of Napoli and Siena. Bye to everybody, and thank you very much.
Bye-bye.
Bye.